Ladies and gentlemen, thank you very much for your participation and welcome to the third APHOG and the SIOP Asia Joint Scientific Virtual Symposium 2023. So my name is Akira Nakagawara, working as a chairman of the Executive Council, APHOG. So APHOG stands for Asian Pediatric Hematology and Oncology Group. Then APHOG is a clinical study group of childhood cancer in Asia. And it was officially founded just 2 years and a half ago, although its actual kickoff meeting was held in 2012, 11 years ago. So Asia is very large and occupies about 60% of world population. So therefore, we have almost 250,000 children with cancer in Asia in a year. The cure rate of childhood cancer in each country in Asia ranges from 0 to 80%. According to the grade of national income. Unfortunately, about more than 80% belong to the low and middle income countries in Asia. To conquer such terrible conditions, APHOG started to work very closely with SIOP Asia, just like two fields of a cart. So today, we have a joint symposium entitled TALL and T Lymphoma, and that is supported by SIOP and NGO, Magokoro Organization for Childhood Cancer, MOCC MOC. Please enjoy. Thank you. Then now, Dr. Hiroki Hori, Continental President of SIOP Asia, gives another opening remark. Hiroki, please.
Okay, thank you, introduction. Good afternoon and good evening. I'm Hiroki Hori, the Continental President of SIOP Asia. I would like to express my gratitude to all participants for attending this third APHOG and SIOP Asia Joint Scientific Symposium 2023. In this meeting, we are inviting the outstanding pediatric oncologists working on the treatment for T-cell ALL and lymphoma. As you know, the leukemia is one of the 6 index cancer in WHO GICC. I hope this symposium will be an opportunity to learn the advancement in T-cell malignancy with our colleague in Asia. I thank the moderator and speakers for your great contribution to this symposium. Thank you.
Okay, now start the symposium. Dr. Chi-Kong Lee, please.
Okay. Thank you, Akira and Hiroki, for the opening remarks of this scientific symposium. And actually, tonight we are very fortunate to have 3 eminent speakers talking about the TALL and T lymphoma. The reason why we chose this topic is because this is one of the challenging oncological conditions that we pediatric oncologists are facing. Even though there are some excellent results reported by the COG for the T-cell ALL, however, these excellent results may not be duplicated in other parts of the world, and especially for those who relapse. In fact, these people are having rather poor prognosis. But nowadays, we have more tools and new techniques that may help to achieve control, and hoping that we can also cure some of these patients who relapsed after the frontline treatment. And I believe Dr. David Teachey and Dr. Benshang will share with us their new findings. But more important is when we are using some new drugs, one of the issues that we face in the Asia continent is the expensive cost of the drug treatment. Like the Nelarabine and the other new agents are also very expensive, may not be affordable to some of our patients and their families. So we will also have a very interesting talk from Dr. Alice Yu, will be sharing with us with some old drugs that may help to control the disease. So without further ado, may I firstly introduce our first speaker, Dr. David Teachey. And Dr. Teachey is a professor of pediatrics in the Division of Oncology at the Children's Hospital of Philadelphia and the Perelman School of Medicine at the University of Pennsylvania. He is a very well-known physician scientist with clinical and research expertise focused on developing novel therapies for children with ALL and other rare inherited autoimmune diseases. And he studies new therapies in preclinical models in his research laboratory and translates these therapies into clinical trials. And he is a PI on multiple clinical trials and also performed correlative studies for these trials in his lab. He's now the vice chair of the ALL biology for the COG and also the director of clinical research for the Center of Childhood Cancer Research at CHOP. So may we welcome Dr. Teachey to give his talk on using disease biology to understand differential response to novel therapeutics in T-cell ALL and T-cell lymphoblastic leukemia. David, please.
Thank you very much. I appreciate the kind introduction. Let me just share my screen really quick. Can you see my slides okay?
Yes.
Okay, good. So again, thanks for the kind introduction. It's an honor and privilege to be here to speak today. My only sadness is the fact that I'm not there to see all of you in person. I'm going to talk, my talk is going to go through some results of some recent COG trials as mentioned, and then really talk about some new insights we have in disease biology, which is helping us understand some of the differential response to novel therapies in T-cell acute lymphoblastic leukemia and lymphoma. And I think that'll dovetail nicely into the next two talks, which are going to focus on some of those new therapies for T-cell acute lymphoblastic leukemia and lymphoma. These are my disclosures. I'm not going to go through them. So I think the improvement in cure rates for patients with acute lymphoblastic leukemia is one of the great success stories in modern medicine. And I think one thing that's really impressive is while T-cell acute lymphoblastic leukemia used to have markedly inferior survival compared to B-cell acute lymphoblastic leukemia, with more modern therapies, the improvement in outcomes for T-ALL are mirroring those of B-ALL. Similarly, patients with T-cell lymphoblastic lymphoma now have outcomes that are similar to what we see in B-cell acute lymphoblastic leukemia in most cooperative groups. Unfortunately, as was mentioned before as part of the introduction, while we're much better at treating newly diagnosed patients of T-ALL and T-cell lymphoblastic lymphoma, we're still not very good at treating patients who relapse, and it's very hard to salvage these patients, partially because we're moving a lot of our best therapies to the front line, but the needle really hasn't moved, and for patients who relapse, the odds of cure are less than 40% of T-ALL, and even worse in patients of T-cell lymphoblastic lymphoma, where these patients tend to even be harder to salvage when they relapse. So we need to figure out better ways to treat these patients. And how did we get here? How did we improve the cure rates in patients of T-cell acute lymphoblastic leukemia and lymphoma? And it's really been through combinations of conventional cytotoxic agents, drugs that were all discovered or developed between the 1940s and the 1980s. And through doing that, the outcomes for patients with T-ALL and T-cell lymphoma have become almost superimposable in the newly diagnosed setting. In the older days, most cooperative groups treated T-cell lymphoma differently than T-cell leukemia, but their therapies kind of harmonized when using conventional cytotoxic chemotherapies. In contrast, I'm going to kind of go through some of the results of two recent phase 3 clinical trials for the Children's Oncology Group, where we started to integrate novel therapies into our backbone, and now we're starting to see some differences in response in patients of T-cell leukemia and lymphoma. The first trial to mention is the ALL-0434 clinical trial. This is a trial that was chaired by Stuart Winter and Kim Dunsmore. It included a 2x2 pseudofactorial randomization where patients with T-cell acute lymphoblastic leukemia were randomized to receive Capezi methotrexate or high-dose methotrexate, where superior disease-free and overall survival was seen as Capezi methotrexate as compared to high-dose methotrexate. Patients with T-cell acute lymphoblastic leukemia who were not low risk, which is a very small percentage of patients, less than 8%, were also randomized to receive or not receive 6 courses of nelarabine. Nelarabine did improve disease-free survival in this patient group, and it did it through the reduction in CNS relapses. T-cell lymphoma patients were also randomized, high-risk ones, to receive or not receive nelarabine, and there were no differences in outcome in nelarabine in the T-cell lymphoma patients. Something I used to argue was probably because it was underpowered, it was a small group, but I actually believe now is more driven by the biology that lymphoma doesn't benefit from nelarabine, at least in the frontline setting, the same way leukemia patients do. The successor trial to ALL-0434 was the ALL-1231 trial run for the Children's Oncology Group. This was a trial that I was the study chair. This trial made 2 big changes compared to the predecessor trial. One, it changed the backbone somewhat to mirror some data from Europe and switched from using prednisone to a dexamethasone-based induction, and also added a couple extra doses of asparaginase. And the reason we did this was to eliminate cranial radiation in the majority of patients with T-ALL. On the 0434 trial, over 90% of patients received cranial radiation, either prophylactic or therapeutic. On the 1231 trial, the goal was to get that to less than 10%. The second major thing we did on this trial was we randomized patients with both T-cell leukemia and lymphoma to receive or not receive the proteasome inhibitor bortezomib, given during induction and delayed intensification, 4 doses in each block. We made the same changes to the backbone in lymphoma that we made in leukemia, even though those patients were not getting radiation on the predecessor trial anyways, with the hypothesis that they may benefit from more intensified backbone, dexamethasone, and asparaginase. This trial did close early, after the results of the 0434 trial were released, but it probably wouldn't have made a difference if it had completed accrual. And what we were not expecting to see, and were surprised to see, was in the patients of T-cell acute lymphoblastic leukemia, there was no difference in event-free or overall survival, and these results have now held up past 5 years in patients of T-ALL. In contrast, in patients of T-cell lymphoblastic lymphoma, there was a marked improvement in outcomes, both for your EFS and OS. Even though this was a small number of patients, only 100 per arm, we saw an over 10% difference in outcome with the addition of bortezomib. The other thing that we noticed on this trial was that patients of T-cell lymphoma who were on the control arm, who had the intensified backbone that included dexamethasone and extra asparaginase, actually did worse than historical control and did worse than they did on the predecessor trial 0434. We made these changes to eliminate cranial radiation. Patients of T-cell lymphoma tend not to present in their CNS. They're less likely to relapse in their CNS, and they don't get cranial radiation as their standard. And what we found was by intensifying the backbone in leukemia patients, while there was more treatment-related mortality, that was offset by the improvement in outcomes of dexamethasone. In contrast, patients of T-cell lymphoma had the worsened toxicity with the use of dexamethasone as compared to prednisone, without any of the benefit in a reduction in relapse rates. Of note, the difference in outcomes in the bortezomib arm compared to the no bortezomib arm were all based on a reduction of relapse and progressive disease. So while the control arm did worse, bortezomib was effective at improving relapse rates and relapse-free survival. One of the goals on this trial was actually to eliminate cranial radiation in patients of TALL, and we were successful in doing so. This is showing just a breakdown, and I won't go through it all, of patients on the different arms on 0434 compared to 1231, and outcomes comparing similar patients on 0434 who received radiation to those on 1231 who did not, showing similar outcomes across the trials. Another thing that we noticed when we were starting to look at our patients of T-cell leukemia and lymphoma was that we're seeing differences in outcome in the US, at least, based on self-reported race and ethnicity. So self-reported race and ethnicity are social constructs across many cancers. There's been shown that there's differences in outcome, and patients who self-report as Black or African American in the US tend to do worse. We were surprised to see that patients of T-cell acute lymphoblastic leukemia had no difference in outcome based on self-reported race or ethnicity. In contrast, patients with T-cell lymphoblastic lymphoma have worsened outcomes if they self-report as Black as compared to those who are white. So another thing that highlights differences between these two diseases. Very briefly, without going into the data, some of our recent relapse trials. The 07P1 trial tested bortezomib in relapsed leukemia and lymphoma. This is a trial chaired by Terza Horton. This is what led to the 1231 trial. And there was the Delphinius trial, which tested daratumumab in relapsed acute lymphoblastic leukemia and lymphoma. This trial was recently presented at EHA and ASCO. On both of these trials, the CR rate after one block of therapy in T-cell leukemia was around 65%. In contrast, the CR rate after one block of therapy in T-cell lymphoma was half that. Similarly, after 2 blocks of therapy on both trials, the CR2 rate was over 70%. On the right is showing some of the Delphinius data, showing the CR2 rate after that. But again, the patients with lymphoma had about half the salvage rate with the same types of therapy, and also worse EFS and OS. So in the past 30 years, while there's been harmonization of therapy of TALL and T-cell lymphoma and similar outcomes when treated with more traditional cytotoxic, we've made some recent observations that T-cell lymphoma patients, but not leukemia patients, had improved EFS and OS with bortezomib. Leukemia but not lymphoma patients benefited from intensified corticosteroids. Leukemia but not lymphoma patients had improved outcomes with nelarabine. T-cell lymphoma patients but not leukemia patients have differences in outcome based on self-reported race and ethnicity. And numbers are small, but T-cell lymphoma tends to do much worse in relapse. So how do we try to figure out why are we seeing these new differences as we integrate novel therapies? And I will also mention before I get into that, based on these results, at least in the Children's Oncology group, while we had treated T-cell leukemia and lymphoma patients the same, we now, as our standard, treat them very differently. T-cell leukemia patients, we treat with dexamethasone-based backbone. We treat them with nelarabine. And T-cell lymphoma patients, we give a prednisone-based backbone that includes bortezomib as our standard of care. It's made it a little bit more difficult to do frontline trials because we used to be able to pool these patients to ask randomized questions like on 1231, and now we need to separate them into separate cohorts and ask different questions in the different groups. But as I mentioned, we're trying to figure out why we're seeing some of these differences in T-cell leukemia and lymphoma with novel therapeutics. And we're taking a step back and starting to look at the biology, both of the tumor cells and the microenvironment. And I'm going to show some of those data, mostly focused on TALL because the T-cell lymphoma work is a little less mature. This is a collaborative effort between COG and St. Jude, spearheaded by myself and Charles Mulligan, where we did bulk genomic profiling of TALL, over 1,300 cases treated on the 0434 trial, and those sequencing are complete, and I'll show the data. We're also in the process of sequencing patients in the 1231 trial, and this included whole genome sequencing, whole exome sequencing, and RNA-seq of tumor, and whole genome sequencing of germline. We're also doing bulk genomic profiling in T-cell lymphoma. I'm only going to show one little snapshot of that data. And we're also doing single-cell genomic profiling, both T-cell acute lymphoblastic leukemia and lymphoma. And I'll show some of those data trying to understand differential response to therapy. The bulk genomic data I'm going to show today was led by extremely talented postdoc Petri Polonen, and the single-cell data was led by extremely talented postdoc Jason Zhu, and that was in collaboration with Kai Tan. So one, why do we even need to do bulk sequencing in patients with T-cell acute lymphoblastic leukemia and lymphoma? Don't we know the answers here? And I think the issue is there's few published studies that actually did whole genome sequencing in this disease. Many of those published studies excluded patients with refractory or relapse disease because typically we use the remission sample as our source of germline DNA, and a lot of patients with TLL don't get in remission. And because the studies were small, they were underpowered to correlate with genomics and outcomes, and they focused on TLL. So through doing comprehensive genomic profiling on over 1,300 cases of TLL with whole genome sequencing and RNA-seq, we now are able to better understand the biology of TLL. This is on the left showing a UMAP, which each dot represents a case, and we're able to subdivide patients of TLL into 15 different groups based on an integration of RNA-seq and whole genome sequencing. In these groups, we now can understand and identify the leukemic driver in the vast majority of cases. There's an oncoprint on the right. Just out of time, I won't be able to go through all these data. I could probably talk for 2 hours just on the genomics that we've discovered so far. We were able to identify the disease classifying driver in over 90% of patients. Most of these things were ones that we've seen before and are known, like Tau1, TLX3, et cetera. There were a small number of cases that we're still trying to dive in with long-read sequencing and other technologies to identify the driver. Typically, the drivers are mutually exclusive. And one thing that had been alluded to potentially in some very small series, but never studied comprehensively, was the impact of non-coding alterations in TLL. And what we found was almost 60% of the primary leukemic driver in patients with T-cell acute lymphoblastic leukemia are changes in the non-coding part of the genome or intragenic alterations, things that would be missed on next-gen sequencing or whole exome sequencing approaches. And really, to understand the biology of TLL, you have to look at it at a whole genome level. And this could be due to enhancer hijacking, super enhancers, intergenic loss or gains, lots of different mechanisms, a lot of complexity to the mechanisms. For just example, TCR enhancer hijacking, we saw dozens of different genes that had that type of biology that were leading to it. So it wasn't even like a small number of different oncogenes that were involved. It's actually a very complex process. We were able to better characterize the genomic landscape of TLL. We did identify some novel genes that were involved in T-cell leukemogenesis. Most of these things have been discovered before, but we have a better sense of the relative frequency now in patients with TLL. For example, the most common genes that are altered in TLL continue to be CDKN2A and Notch1. And without going into all the different subtypes that I mentioned before, the 15 different ones, and diving them out, I'm going to just highlight on one just to show some of the new biology that we've discovered in TLL of this. And I'm going to focus on early T-cell precursor. So as people know, currently we classify TALL by immunophenotype into early T-cell precursor, which has a more immature T-cell immunophenotype, or near ETP, which has a similar immunophenotype, but instead of being CD5 negative or dim, they're CD5 positive. The blue little square little plus signs here are ETP cases, and the red triangles are near ETP. The other ones are non-ETP. What we found was early T-cell precursor ALL by immunophenotype clustered in 3 groups. One was the TXL3 group. Another was this group, which I'll talk about, which we're renaming the ETP-like group. And another was BCL11B. Near ETP, in contrast, tend to cluster also in TXL3 and this ETP-like group, but they also clustered in the Tau1 alpha-beta-like group. Again, I won't have time to go through those other groups in too much detail just because of time. But drilling down on this ETP-like group, I'm going to talk about that a little bit. This was a group that was made up of a decent percentage of the population that we actually on this 0434 cohort. They had different drivers, things like MED12, MLLT10, KMT2A, NUP212, 214, so we can subdivide this ETP-like group into different ones. And they actually cluster similarly to patients that were not in this cluster but had similar genetic alterations. For example, we saw MLLT10 was its own independent cluster outside of this. And why does that matter? If we looked at the entire cohort of 1,300 patients, about 70% of patients with ETP immunophenotype and 41% of the near ETPs cluster in this ETP-like group. If you look at that ETP-like group another way, it was 235 cases. About a third of them were ETP, a third of them were near ETP, and a third of them were non-ETP. This group as a whole has inferior overall and event-free survival. This is looking at outcome based on the 15 different groups that I mentioned before, where that light purple line is the ETP-like group, where they had inferior outcome of less than 75% EFS in our data set. And if you started to look at their clinical characteristics and their biology in this ETP-like group, comparing and this is ETP defined by genomics, not by immunophenotype, but if you look at the non-ETPs, the near ETPs, and the ETPs by immunophenotype in this group, they are the same. They have the same rates of induction failure. They have the same rates of high MRD. They have the same slow response to therapy that we often talk about in ETP. And they also had the same biology. They had the same genetic lesions at the same frequency, the same dysregulated signaling pathways. So really, it's the genomics that are driving this, not the immunophenotype that we see. Another way to look at it, if you look at outcomes by ETP immunophenotype in this ETP-like group, we found they were the same across the different groups. And if you look at the outcomes based on immunophenotype, comparing patients that clustered together in this ETP-like group compared to all the other ones with the same immunophenotype, we now see why we see differential outcomes on different trials, that if you just do it by immunophenotype, we're clustering and lumping patients together who have favorable outcome with those of unfavorable outcome. If we look at the immunophenotypic level, if we look at it at the genetic level, we can identify this group of patients and actually find the ones that, regardless of immunophenotype, have poor outcomes. So one of the big conclusions we have of this is the whole concept of defining ETP by immunophenotype needs to be tossed, and it really needs to be defined at the genomic level. On that note, if you compare patients in this ETP-like group who have the same genetic alterations, for example, MLL-T10 in the ETP-like group versus MLL-T10 that were not in this ETP-like cluster, we see differences in survival there too, similar with seen of KMT2A and NUP lesions and other lesions, that it really is this poor risk group biology that's driving outcomes in TLL. One thing we were happy to see is now with this more comprehensive genomic data, we're able to risk stratify patients with T-cell acute lymphoblastic leukemia better. This is just one model. We're integrating clinical and genomic data. We can put patients in 4 different groups of different outcomes. Another model, which just uses the expression data into the different subtypes, we're able to risk classify patients into 8 different groups, integrating with MRD of different outcomes. So I think we'll now be able to, in the future, risk stratify patients with TLL, identify those patients who are more likely to relapse and treat them differently, identify very favorable groups, and maybe be able to de-intensify therapy. Unfortunately, the problem is with some of these genomic things is you really need whole genome sequencing to really be able to make some of these risk classifications. The next thing we did, which I'm going to just very touch on briefly, is we did some single-cell profiling of a large number of TLL cases. First, we sequenced normal thymi and normal bone marrow to make a map that we could compare the lineage in our leukemic samples with normal T cells to know where the origin, the cell of origin was. We took a cohort of ETP, near ETP, and non-ETP, and not surprisingly, we found that the ETP cases were more likely by both single-cell RNA-seq and ATAC-seq to be arrested at an earlier lineage state, the pro-T-cell stage instead of pre-T-cell stage, which we saw near ETP and non-ETP. ETP ALL looks more like T myeloid ALL if you look at it at the cell of origin or expression level. We compared a cohort of patients with high MRD with low MRD in our single-cell profiling, and we found that treatment-resistant blasts were arrested in an earlier state, which we call a bone marrow precursor-like state, made up of more stem cell type markers. When we compared the differential expression of genes in this BMP-like cohort versus more of the mature T-specified TLL, the ETPs that don't cluster in that ETP-like group, we found differences in the differentially expressed genes. For example, in the BMP-like, we saw things that were more associated with recovery from genotoxic stress or self-renewal, versus in the more mature, we saw the traditional things we think of in TLL, like not targeting genes. We made xenografts of a large number of these, which we found this BMP-like signature was maintained. We integrated the differentially expressed genes into targeted databases and identified some therapeutic targets for this more high-risk subset, including targeting BCL2, SYK, and BTK. We then worked with Jun Yang's lab to actually take these samples and treat them ex vivo with different chemotherapeutics. And we found this group of MRD positive patients were more likely to respond to novel therapies like the venetoclax and navitoclax and ibrutinib, things we predicted they'd respond to, and be resistant to more traditional chemotherapeutics. And through the single cell work, we were able to identify this BMP-like signature that we didn't see at the bulk omics, but then we applied it to our large genomic data set, and we're able to risk stratify using these 17 genes across ETP, near ETP, and non-ETP cases. So something that's probably a little bit easier to translate into the clinic in the future. One last thing that I'll touch on, and this will be the last thing I really kind of talk about, as I mentioned earlier, that we were surprised to see in TLL no differences in outcome by self-reported race and ethnicity. Instead of doing it by self-reported race and ethnicity, which is a social construct, we decided to look also based on outcomes based on genetic ancestry. And this is using germline SNPs. Different ways of doing this. We collaborated with Jun Yang to look at germline origin. And by looking at it this way, we, again, did not see any difference in patients who are of European or African ancestry. We did see, though, surprisingly improved outcome in patients in North America who have American Indian ancestry, the rough equivalent of Hispanic. This is vastly different than what we see in BLL, where patients of Native American ancestry tend to do markedly worse. We saw that they did better. And we wanted to see, are there differences in outcome based on genetic ancestry, and would this impact now our ability to risk stratify patients? For time, I won't go into this, but just to show one bit of data, if we looked at just Notch pathway alterations based on genetic ancestry in TALL, we found that Notch pathway alterations were highly prognostic in patients of European ancestry. They were also highly prognostic in patients of American Indian ancestry. However, they had no prognostic weight whatsoever in patients of African ancestry. So there's a strong interaction between germline ancestry and your tumor genetics, which probably explains why some of the outcome differences that we've seen in TLL from work in different countries have actually shown differences in outcome based on the same genetics. Why some of the classifiers, for example, the 4-gene classifier that was developed in Europe, holds up in our cohort in European patients of ancestry, but does not prognostic in African patients, and just highlights the fact that not only do we need to do a better job at risk classifying these patients, we also have to account their germline DNA, because risk classifiers that are developed in patients of European descent may not be prognostic in patients of other descents. We did find that there was enrichment of certain genetic subtypes based on ancestry. We didn't have the one problem is we didn't have a ton of patients who self-report or had Asian ancestry in this to actually make any good outcome inferences. We did find differences outcome, but the N was very small and not powered to look at this between patients of East Asian versus South Asian ancestry, with East Asian ancestry and TLL tending to do markedly worse compared to South Asian, but we need to work collaborative, Jun Yang and others, to try to expand the number of patients of Asian ancestry that we're looking at. And then I'll kind of just conclude by saying we're starting to sequence our T-cell lymphoma patients now. I can't show any of those data now, even though we're about halfway through of it. But the hope is by sequencing our lymphoma patients and comparing that with our leukemia patients, we'll start getting a sense of why we're seeing some of these differences in response to therapy in T-cell leukemia and lymphoma. I focus most on our T-cell leukemia data because we have it, but I think we're at the precipice of being able to really understand why these patients are doing differently with some of our novel therapies. So our next steps are to complete the sequencing of our T-cell lymphoma cases, both bulk and single cell, which we're going to integrate and compare to our TLL. We're also sequencing the successor cohort at 0434 on 1231. And the hope is to integrate the data across T-cell leukemia and lymphoma. And a year from now, if I gave the same talk, we'd be able to dive in and to answer some of those questions on differential response and those therapies we talked about in the next two talks. So with that, I'd like to conclude and thank members of my lab who did a lot of this work. Haley Newman did a lot of the genetic ancestry work. I'd like to thank collaborators at my own institution. I mentioned Kai Tan, Jason Zhu, a talented postdoc who did a lot of the single cell work. Collaborators outside of my own institution. A lot of the sequencing was in collaboration with Charles Mulligan, Petri Polonen, very talented postdoc, members of COG, including Minyan Lo, Elizabeth Rates, Minnie DeVitas, Steve Hunger, other people at St. Jude, including Stan Pounds and Jun Yang and people in their labs, and then collaborators that in Europe and across the globe. So with that, thank my funders and families and our patients and families, and open it up for questions. Thank you.
Thank you. Thank you. Dr. Teachey gave a very stimulating talk on this topic, because we are now knowing that just the immunophenotyping is probably just something may not be enough to tell us the prognosis, but the genomic study will be getting more and more new information related to their prognosis. But now we know that not only genomic, but we also with the genetic ancestry, that even the same genetic change may have different prognostic outcome. So it makes us probably getting more and more feeling complicated in this field. But how to apply in the future? We probably need your hard work in the future, telling us what may be the better strategy to deal with these very complicated cases.
It's a great question.
Nope. Yeah.
Oh, is that a question for me or just to the?
Yeah.
So it's a great question. It is. I mean, I wish that our hope was to be like BALL. We'd sequence these patients. We'd be able to divide them in nicely to groups. These are easy to identify based on traditional sequencing approaches, and we could now risk stratify better. Unfortunately, in TLL, we found that most of the driver alterations are non-coding, which makes it very hard to do it without sequencing at the whole genome sequencing level. Fortunately, sequencing has gotten a lot cheaper. I think that if you had said 20 years ago that you need to do whole genome sequencing in any tumor to risk stratify or to understand the biology, people would have laughed because it took like 10 years. It took 20 years just to sequence one genome. Nowadays, people can sequence a genome for a few dollars, and it's getting a lot cheaper. The bioinformatics are getting better. So I think in 10 years, it'll be easy because hopefully sequencing technologies across the globe will be at a point where it's actually much easier to do this. One thing we are trying to do is dive in deeper and see if we can develop some outcome modeling that doesn't necessarily rely on needing whole genome sequencing. That 17 gene signature I mentioned actually is pretty decent at risk classifying patients. It showed the importance, I think, and the power of single cell omics because we didn't identify that on the bulk omics, but that actually is probably something that's more easy to translate into the clinic. We're also starting to look to see if some of these higher risk groups, while ETP may not be, immunophenotype may not be great at risk stratifying patients, we're trying to now take a step back and look at it the other way, where we now know the genomics of who does bad. Are there immunophenotypic signatures that are different in those patients? That would be something that would be much easier to translate into the clinic. And those work are ongoing. And then the hard part with the genetic ancestry is I just think that if we develop any risk models, we have to make sure those risk models actually apply accurately across populations. And what we found, which I didn't have time to show you, is some of the models we developed worked very well in only certain patient groups of certain ancestries. And other models, like that, the bigger classifier I showed, actually hold up pretty well across ancestries. So I think there probably are going to be some things in the genomics that are ancestry interaction and some things that are not. Notch mutations, for example, are the big one, that there's a strong interaction between ancestry and disease biology. Other genetic alterations that correlate with outcome aren't as ancestry driven.
Okay,
I know I didn't really have a great answer, but I think we're still trying to get there.
Yeah. But I hope that in Asia, hoping that in future we can have more studies on the Asian population to see how the genetics and genomics in this part of the world whether they may have similar or different response to the treatment. Okay,
I agree.
May I invite the participants in the webinar to raise any questions? If you want, you can type in the Q&A or in the chat. Up till now, I haven't seen any, but we have already over 70 people joining our webinar now. That's a good response. Okay, if there's no other questions from the audience, so thank you, David, again for your excellent talk. And then we will move on to the second speaker. Thank you.
Thank you so much.
Thank you. Our next speaker is Dr. Alice Yu. And Dr. Yu is well known to us, is a neuroblastoma expert. but today she chose a new topic to share with us is on T-cell ALL, and but just a brief introduction, even though you all know her very well. Alice is the academician of the Academia Silesia in Taiwan. She is the Distinguished Chair Professor and Deputy Director of Institute of Stem Cell and Translational Cancer Research at Chang'an Memorial Hospital and Chang'an University, and also the Professor Emeritus of Pediatrics at the University of California in San Diego. But I won't read out all her introduction, because you all know her. She has been working with excellent work in the immunotherapy for the neuroblastoma, and also she has received many awards for her excellent work in the past decades. So today, Alice will be sharing with us with a very interesting topic. Is repurposing an old drug for TALL or lymphoma. Alice, please.
All right, let me just get my slide up.
Yeah.
Thank you, Chi-Kong.
Yeah, we can see that. Yeah.
Yeah, okay, thank you very much for your kind introduction. Actually, I want to give a big thank to David Teachey, great talk, which will save me a lot of work. Now, he's giving you all the fancy update genomics and molecules. I'm going to take you backward to your days of medical student in biochemistry, okay? So it'll be quite a contrast. So I think we can skip the slide. Basically, ALL is the most common cancer in children, and the T-cell ALL comprise 10 to 15% of ALL. It's it's more common in boys in the older age, a higher white count, and the mediastinal mass, testicular involvement. All these are considered higher risk, and therefore it's not surprising their outcome isn't as good as B type of ALL. Over the last 50 years, we have come a long way in improving the outcome of ALL overall. And as you can see, now its survival is over 90%. However, in early days, we realized that T and the B have different outcome. At that time, that was only immunophenotype, no molecular understanding. But even that, you can see that this is back in 3-4 decades ago, okay, showing that B precursor, younger age, is doing better than older age. For T, they are as bad as older age, I mean, whether they are older or not. However, David has shown you more recent outcome with more intensive chemotherapy. We have now improved the survival of the T-cell ALL. But I want to take you back to your old days of biochemistry, talking about 2 enzymes that is particularly important for T-cell, T lymphocyte. It all started out with the work of Dr. Elios Giblet, in 1972. She's a hematologist in blood bank, and she described deficiency of adenosine deaminase as the cause of severe combined immunodeficiency. And these children have, no T cell or barely any, and also B cell dysfunction. 3 years later, she reported another enzyme, purine nucleoside phosphorylase. And deficiency of this enzyme mainly affect T cells. So we know these are both so-called, purine metabolizing enzymes. And adenosine deaminase basically can take adenosine, here's the structure of adenosine, deaminate that to inosine, okay? And it also works on deoxyadenosine and changing it to deoxyinosine. And the purine nucleoside phosphorylase, or PNP, on the other hand, basically convert the adenosine and guanosine, basically, to remove their sugar to become adenine nucleotide, to be, so nucleoside to nucleotide. So why are those enzymes so important? Normally, we know that the enzyme deficiency can cause problem by either, lack in the substrate is toxic because you don't have the enzyme, the substrate will accumulate, or the other way will be the product is essential, ribose or inosine. In both cases, we know it's the substrate accumulation that cause harm. And this is shown here. Simply, if we start with adenosine or deoxyadenosine, without the ADA, then the adenosine will accumulate and they will be converted into deoxy ATP. And the deoxy ATP is a potent inhibitor of so-called ribonucleotide reductase, okay? So that means you cannot make the rest of the DGTP, DCTP, which is important for DNA synthesis, okay? So this causes, a lymphocyte to die. Now for PNP here, it basically converts the guanosine into guanine by taking out the sugar. Now, with accumulation, when PNP is out of order, you have accumulation of deoxyguanosine with GTP, deoxy-GTP, again, that cause DNA synthesis inhibition and cell death, okay? So these are all especially very important for T cell survival. And then the idea is, can we exploit these two enzymes somehow for the treatment of T cell malignancies? Okay, so this is all done in late 1970s. Deoxychloromycin was first isolated from streptomyces by a chemist in Park Davis. If you look at the structure of deoxychloromycin, it looks just like deoxyadenosine, isn't it? Except that this is a 7-ring instead of 6-ring base, okay? So because it looks just like deoxyadenosine, it can bind to ADA and then make it irreversibly inhibited, okay? So then it paralyzed the ADA. And then later on, it was found that in TALL, ADA activity is very high. So how does deoxychloromycin cause harm in TALL? It will cause accumulation of substrate, adenosine. When you have too much adenosine, then you have S-adenosine homocysteine, which is important for methylation, nucleic acid, okay? So it will disrupt the methylation process. And the other substrate, deoxyadenosine, which I mentioned before, actually become converted to deoxy ATP, then inhibit the DNA synthesis. So at that time, wait a minute, I'm blocked. Let me see, how do I advance the screen? Okay, John Smith from England got an IND from Park Davis to perform some trial of deoxychloromycin. He's the one who reported the very high ADA activity in T cell leukemia compared to a B lineage and a normal lymphocyte. So I will talk about deoxychloromycin in a moment, but I want to introduce the other enzyme, purine nucleoside phosphorylase, okay? Another enzyme that is crucial for T cell survival. and inhibitor, or to take advantage of PMP will be something related to guanosine. And this is a nelarabine. Okay, it's an ARA-G prodrug. This was the invention or the generation of this new drug. Actually, we have to give credit to the Nobel laureate, Gertrude Elion, a chemist who made many of the drugs we all know and we all use these days. 6-methylcaptopurine as a thiopurine for Imuran, okay? Allopurinol for gout, and trimethoprim, acyclovir, and so forth, okay? So she's the one who's really good at synthesizing all kinds of purine analogs. And through that, ARA-G was made. So ARA-G basically is like a guanosine, except that this ribose group is replaced by araminoside. This is like ARA-C, so it's ARA-G instead of ARA-C. And the ARA-G cannot be metabolized by PMP. The problem is that ARA-G is not water soluble. So someone else then in Burroughs Wellcome, I think, made a methoxy analog, and that made it much more water soluble. And that's our nelarabine. Basically, it's converted by ADA into ARA-G, and ARA-G is then converted into ARA-GTP because PMP cannot metabolize it, okay? So again, Julie Blatt in Duke University, they show that in contrast to ADA, PMP is very low in T-cell leukemia. So if our idea is to produce some substrate for PMP, then you don't need very many to get T-cell toxic. So now I go back to Dr. Smith in England. When he got the IND, he started treating T-cell leukemia. So the first case is a 7-year-old girl with T-cell leukemia in a first relapse, but it's a very short first remission anyway in this patient. And after a course of deoxycofomycin, at that time it was 7.5 milligram per meter square per day for 5 days, consider one course. This is the white count. There is a drop of white count in the blast actually, and the patient actually went into remission, allowing autologous marrow transplant at that time. And then stay in remission for a while, but then blast came back, and then she was given several more courses of deoxycofomycin that kept her, in shape until she developed measles and then died of complication from infection. A second patient is a 28-year-old male with TALL in second remission. And when the blast was coming up, he started the deoxycofomycin, and one can see that there is a rapid drop in his blast count. And then he also went into remission and stayed in it for a few weeks. Then he developed a CNS leukemia and died from it. So when I heard about John Smith's work, I got an IND with his help, from UK to USA, and started working with deoxycofomycin on T-cell leukemia. And this is in vitro, showing that the deoxycofomycin alone, you can't really show any toxicity because there aren't that many endogenous deoxyadenosine. You have to add exogenously. So when you added deoxyadenosine and with increasing concentration, different patient has different sensitivity, but basically their survival will be inhibited. And on the other hand, normal bone marrow is relatively resistant. So I started treating a patient with TALL in relapse. This is a patient is in his fourth relapse, 2 years from diagnosis, okay? And his blast count was too high for me to start anything. So we started with a dose of cyclophosphamide to reduce the tumor burden, and started the deoxycholic 7 days later. And here's his white count. It was still increasing initially. The treatment is 5 days, okay? Increased to up to third day and then plummeted, dropped down, and with neutrophil beginning to show up. And this line shows the thymidine incorporation, showing that the peripheral blood blast actually stopped making DNA synthesis. Unfortunately, on day 5 of this last dose of treatment, the patient developed tonsillitis, even though he went through appendectomy, but then it was followed by pseudomonas sepsis, and the patient passed away. Okay, but this is just a beginner of some activity of deoxycholic in TALL. Now I want to sidetrack a little bit to show you. At that time, a big puzzlement for us. We saw that from peripheral blood smear, you can see these odd-looking cell that's no longer intact cell. They are kind of fragmented, and I call it with blabbing in the nuclear fragmentation. Indeed, in electron microscopy, you can see the nucleus are fragmented. And this is the energy-dependent process. At 4 degrees, it doesn't happen. It requires 37 degrees. And also, you need glucose transport. So without glucose transport by cytochalasin B, it doesn't happen either. So I know these days, you look at this, you say that's apoptosis, but this is back in 1980s, okay? The word of apoptosis is not there yet. And we know that this is the apoptotic cells, and it's correlated with accumulation of deoxy-ATP, but ATP really did not change. So it wasn't because of loss of ATP, it's the deoxy-ATP accumulation that caused the problem. And later on, I started working with adult patients with CLL. And I just want to share with you one patient. This is a patient that has been refractory for some time. So diagnosed in 1975, and by the time he's refractory to many other drugs, in 1983, we begin to give him pentostatin or deoxycholic. After a single dose, his blast count went way down and remained down for a few months. And then it came up again, we give another dose, it went down again. So he was exquisitely sensitive to this medication. And then later on, though, he developed autoimmune hemolytic anemia and, died from complication. With that, actually, other group in the USA also begin to do trial of CLL, and basically they all see some kind of response. So if you take all different different groups, the 25% overall response was found in CLL. But that's also not very lasting in some cases. However, that's not the case when hairy cell leukemia was treated. Okay, you see a 98% CRPR in one of the first trial, and then the duration of responsiveness is quite high. That caused some excitement. As you can tell, as you know, hairy cell leukemia is sort of a 2% of adult leukemia. It has, the leukemic cell has this hairy border or fluffy, border. And usually it's associated with pancytopenia, including monocytopenia, and increased susceptibility to infection. And they can also develop autoimmune thrombocytopenia, hemolytic anemia. If not treated, the median survival is 4 years. At that time, the standard of care is interferon alpha. And if spleen is big, you take it out. So it can control it for some time, but not curative. However, when deoxycarbamazine came to scene, it changed the history of hairy cell leukemia. This is a summary of all different trials. As you can see, the complete response rate ranged from 72% to 100%, with median disease-free survival of 16 years. And it's from all these trials, deoxycarbamazine was approved by FDA with a trade name of Nipent or pentostatin, okay? And that is for as a first-line treatment for hairy cell leukemia. Okay, now at that time, I was also interested in doing salvage treatment for T-cell leukemia using deoxycarbamazine. And this is also back 30 years ago, okay? So patients in first relapse were induced for second remission. At that time, we don't have very intensive drug, as you can tell. The CR rate is not very impressive, second CR. And they are then randomized to so-called standard of care IV methotrexate 6-MP alternating with oral 6-MP methotrexate. And the other arm will then add the IV deoxycarbamazine together with the maintenance therapy. So this is also the very first trial combining deoxycarbamazine with chemotherapy. And it was well tolerated without the renal or CNS toxicity, because at higher dose, it's known to cause kidney problem and cause CNS toxicity, including seizures, okay? Unfortunately, the sample size is really too small. With DCF or without DCF totally, we have 69 patients randomized. And the dashed line shows that the deoxycarbamazine arm, it's a little better, but did not reach statistical significance with this small sample size. So even though, the other problem is at that time, like I say, the salvage chemotherapy is pretty meager compared to what we have these days. So the second remission is only 4 months long and make it difficult to compare. But indeed, in the 4 patients on the deoxycarbamazine arm was able to finish the 2-year treatment and remained in remission at a long time, actually. So now we have come to the nelarabine era, okay? I guess I'm skipping the early work. Now I'll go to the most recent report by Japanese group combining adult and children T-cell ALL. And they randomized, it's not a randomized study. So it's a phase 2 study by giving nelarabine for high risk and a very high risk group. So as you can see, very high, high risk and the standard risk without nelarabine has similar EFS and OS, okay? Very high risk actually isn't doing too bad, okay? So they also show that addition of nelarabine to their BFM backbone is well tolerated. And now this is a study that David already told you, the COG study randomized the high-risk patient into with and without nelarabine. I'm only showing you the Capizzi arms, okay? So basically, the nelarabine group actually has a better event-free survival, but the overall survival is not statistically significant. More importantly, it does show less CNS relapse with nelarabine. So it's at 1.3% compared to 6.9%. Okay, so what about the toxicity of using nelarabine? There are the most fearful one is the neurotoxicity. For central neurotoxicity, actually the 2 arms, it looks like the experimental arm is a little bit more CNS toxicity, but p-value is not significant. What about peripheral neurotoxicity? If we look at the motor neuropathy, again, there's a trend that maybe the nelarabine has a little bit worse, but the p-value is not significant. And sensory neuropathy, there's no difference. So this slide sort of summarizes what we know about the comparing the two, to compare the two T cell targeting agent from biochemical point of view, okay? For nelarabine, the dose is much higher. For children, it's 650 milligram per meter square per day for 5 days. That's one course. And for pentostatin or deoxychlorophomicin, it's 4 milligram per meter square every 1 to 2 weeks, actually. For hairy cell, every 2 weeks. And approved indication is TLL, T lymphoma, I think, for nelarabine. For pentostatin, it's hairy cell leukemia. What about toxicities? They are pretty comfortable, okay? Myelosuppression fever and the liver function, but the neurological abnormality seems to be more frequent in nelarabine compared to deoxychlorophomicin. You only see that when you use a dose higher than 10 milligram per meter square, but these days people don't really go that far anyway, okay? The patent status, nelarabine is still active, but the patent for pentostatin has expired. And that also reflects the price. The cost of care per month is $19,400 for nelarabine, and for pentostatin, it's $1,700 something. So it's 13%, I mean, 13-fold cheaper, okay? So this is why I think maybe for the APHOG group and low middle income countries, we should think about pushing for a new indication for pentostatin. It's cheaper and it's probably less neurotoxicity, although we don't know that, okay, until we do the test. And the easier way is just to copy the COG study and replace nelarabine with a pentostatin, or we can change whatever backbone we like. But I'm just throwing this out to see if APHOG would like to take this idea on and develop a randomized trial of T-cell leukemia using an old drug for new indication. I'd like to thank you all for attention.
Thank you, Alice, for this very excellent talk on using a new old drug for possible new indication, and also share with us about our basic chemistry data about the pathogenesis and the mechanism of these agents in controlling the leukemia. I think this is a very important topic, that if we can identify some effective agents that have some anecdotal or early results showing some actions that may help in control of the leukemia, that is certainly something we should consider, especially we are now facing with the very high treatment costs for using some new agents like the nelarabine, and I believe not too many countries can now afford to use nelarabine as a routine frontline treatment in their protocols. But I believe we need to have really a well-designed clinical trial to test on a new agent. I won't call it new because it has been there for decades, but a new indications that how to use it is important. Now, what Alice proposes to be similar to that of Nelarabine, to replace it and by the pentostatin. Now, certainly, that is one option that people may consider. But will there be some other options you consider may also be applicable in our in this part of the world, as it is so cheap? And in one of your study that you performed many years ago in the 80s, you are putting the pentostatin during the maintenance.
Right.
And so my question is, will the when should be the most suitable timing to introduce pentostatin? Is that in the induction consolidation phase, or in the maintenance phase, or actually all through from the induction back to the end of the treatment? Do you have any suggestions on that?
Yes, I do. It's a great question. And I know definitely not induction, okay? The tumor load is so high, and they will be loaded with deoxyadenosine. And if you give them deoxycobramycin at that time, you are guaranteed to have neurotoxicity, okay? So it's an accumulation of the substrate that cause harm. And when deoxyadenosine is too high, there are CNS toxicity. And this is why Nelarabine, when deoxyguanosine or ARG got too high, you have neurotoxicity. So you will want to start when the tumor burden is relatively small. So one can do it during consolidation at best, as early as, I wouldn't go before induction, but after induction, if they are in CR, then go into consolidation or delayed intensification phase. That's how I would use it, and then continue through the maintenance phase.
Okay, thank you. I noticed that there is a question on the Q&A. The question is why it works in hairy cell leukemia but not in other leukemias?
Very good question. Okay. I guess hairy cell leukemia, it's a slow growing, relatively, slow growing T cells. And I guess when they are inhibited or when they are killed, it's not so easy for them to come back. On the other hand, CLL is a B lineage, so it's not as sensitive as T cell. And why is that? I don't really know. Biochemically, I don't know enough to address that.
Okay. So thank you. Puna, you have questions?
Yes. I joined. I was traveling, but I have been able to join from the airport. And I have only one question, Alice, that will you consider in today's time for a TALL or lymphoblastic lymphoma relapse who goes in remission with a salvage therapy to reach, generally we come across a situation of not being able to reach the MRD negative status, which makes the patient eligible for transplant, short of CAR-T therapy. So will this approach with pentostatin help in achieving that last mile or last bit to make the patient eligible for allogenic transplant without much toxicity? Because we have to balance between the patient's integrity for transplant, overall health integrity for transplant vis-a-vis the MRD status.
Yes, I understand your dilemma. You don't want to hit them too hard, and hopefully it will be effective. It's possible in that setting, it may, because the tumor burden, I think in my trials 30 years ago, okay, at that time, I'm sure we don't have MRD testing at that time. I'm sure majority of those second CR are MRD positive. Okay, and then we were using very, very low intensity chemotherapy. I would think that if you can add that to the deoxychondromycin, just add chemotherapy with pentostatin for those with MRD that you couldn't eradicate, there is a chance that you can help them.
Thank you.
Okay, thank you. Since we are over one, so we still have two last questions. So after these two questions, we will not entertain further questions. The first one is, do you envisage increased risk of infection and infectious complication with pentostatin? This is especially important factor in LMICs. And also the second question is, what's your experience about nelarabine-induced neuropathy? Is it reversible or any specific strategies to treat?
Okay. As far as infection, yes, it is. It can be a problem because you are basically wiping out normal T cell as well. Okay, so the patient susceptibility to opportunistic infection is increased. So we need to consider some antibiotics prophylaxis when you use the pentostatin or nelarabine for that matter. As far as neurotoxicities, it all depends on how severe it is. For the CNS, fatal toxicity has happened before, okay? But the majority of those are reversible. So I can only say, and pentostatin in old days, it can also, when we didn't know what the dose to use, when we were going at 10 milligram per meter square, we are seeing seizures and sometimes even fatal neurotoxicities, but it's all dose related. Yeah.
Okay. Now I think we have to move on. Otherwise, we cannot have dinner for some of our colleagues. So thanks again, Alice, for the excellent talk. And I think we should really seriously talking with other colleagues to see whether there is a possibility of starting a new clinical trial of these very attractive agents. Okay, now we will move on with our last talk today. Is to be given by Professor Benshang Li. Dr. Li is the Deputy Director of Hematology Oncology Department at the Shanghai Children's Medical Center at the Shanghai Jiao Tong University School of Medicine. And he is also the Director of the Hematology Oncology Laboratory. And he is expert in diagnosis of hereditary hematological diseases and treatment of relapsed and refractory child leukemia. And he has been working especially working very hard on the CAR-T therapy, not only on leukemia, but also extending to solid tumor. And so I won't go into all the long list of his important posts in the different societies, but probably you have been, some of you have read his article on the CD19 and CD22 CAR-T therapy for acute lymphoblastic leukemia for the BALL. But today we are fortunate to have Dr. Li to share with us about his experience on the CAR-T therapy for relapsed and refractory T-ALL or non-Hodgkin lymphomas. Dr. Li, please. You can share your slide now. Yeah. Yeah, we can see that. Thank you.
Hello, everyone. Good afternoon and good evening. And thanks for Professor Li for his instruction and invitation. Sorry, my English is not so good, and I speak slowly so that everyone can understand. I'm from Shanghai Children's Medical Center, and I focus on the diagnosis and treatment of refractory and relapsed pediatric acute leukemia, lymphoma, and solid tumors from 2014. we began to study how to treat this kind of disease by using CAR-T, and we gradually accumulate some experience in this area. We really want to share with everyone. The title of my presentation is CAR-T for relapsed refractory T-ALL lymphoma, strategy and measures. In fact, to T-ALL, we are not doing very well. The difficulty of CAR-T for this disease is much higher than that for the B lineage. And we still have many unresolved problems. We are treating well, also think about methods such as targets, CAR structure, clinical usage, patient management, and so on. We are also gradually accumulate some experience during this clinical process.
Your slide is not moving. Yeah, we can see the new slide.
Okay, a few words about CAR-T. CAR-T is chimeric antigen receptor T-cell immunotherapy. The VH and VL is the SCFV of an antibody. The CAR structure includes the SCFV, the hinge, the transmembrane domain, co-stimulator such as CD28, 4-1BB, OX40, and the C-cell delta. The CAR sequence were inserted to a lentivirus vector. Then the virus was packaged in 293 cells, and the virus title and the transduction efficiency were detected. This figure is CD19 CAR. CD19 CAR expressed on the cell. The CD19 CAR expressed on the cell member of T cell. It can bind in CD19 positive leukemia cells by anti-CD19 antibody of the CAR. After binding, the transformation of CD19 antibody activate the T cell to secrete foreign granules and some cytokines to kill target cell. The co-stimulator further activates this process and promote CAR T cell to exert cytotoxic effects and large proliferation. In my laboratory, we co-culture CD19 CAR and the leukemia cell together. Leukemia cell were transducted with GFP lentivirus. Under a laser confocal microscope, we take pictures every 10 seconds and continuously capture them for 12 hours before making a video. This way, we can see the entire process of CAR T cell killing leukemia cells. The colorless and the transparent ones are CAR T cell. The green ones are leukemia cell, and in the end, CAR T cell kill all leukemia cells. To BL, we have 3 clinical trials. The first trial is from 2017 to 2019. We enrolled 48 relapsed refractory BL patients and treated with CD19 CAR. Even though the CR rate of CD19 CAR is high, the relapse rate after CAR T in the short and the long term is now also high. And we are very satisfied with this result. Now we think of target to CD19 only in far from enough. Considering the CD22 expression is very high in BL, we prepared the 2 candle of CAR and put it together before inject to patients. That is co-administration, and it is our second trial. From 2019 and 2021, we enrolled 225 patients in this trial and co-administrated with CD19 and CD20 CAR together. The relapse has greatly decreased after CAR T, but there were still many patients who relapsed, and about 1/3 of patients require bridging BMT after CAR. after CAR-T. This trial was successful, but the results were still not so good. Double target CAR need the balance between the two CAR. We found CD19 CAR was more robust than CD22 CAR. CD19 CAR can reach this peak level in vivo within 7 to 8 days, but CD22 CAR needs 10 to 11 days. So we modified our CAR structure and adopt bisystronic structure to construct the CD22 double CAR. From 2022 to present, we have enrolled 290 relapsed refractory BL patients in the third trial. The bisystronic CD19 CAR this group. Compared with the second trial, the relapse was further reduced after CAR-T. And the most important was that the population of patients using transplantation after CAR-T was significantly reduced, about 5 to 6% relative to 34 in the second trial. This table is the patient's characteristic. The third trial had more CSL. There have 82 patients, and 19 patient cases received Benshang and relapse before joining the third trial. This table shows the treatment outcome of our three trials. The response are all very high, 99 for the second and third trial. 1 year even free survival for the second and for second trial is 76% and 81% for the third trial. The overall survival of third trial turned 95%, and only 5.5% patients bridging transplantation after CAR-T. In addition, the relapse rate after CAR-T is 12% in bisystronic groups, compared with 32 in the co-administration group. The relapse patient numbers largely decreased in bisystronic group. As the follow-up time is short, it still needs a long-term observation. This figure shows the event-free survival and overall survival of our three trials. The 1 year EFS for bisystronic group co-administration and the CD19 CAR group were 81, 76, and 41%, respectively. The 1 year overall survival for bisystronic group co-administration and the CD19 CAR group were 95, 88, and 62%, respectively. The result makes us a little happy that the overall survival has reached 95%, which attained or even exceeded the chemotherapy prognosis of new diagnostic patients. This figure shows the bridging BMT or not after CAR-T in 2 recent trials. 78 cases of patients bridging BMT after co-administration trial. The 2 year EFS were 81% and 72% for patients bridging BMT or not, respectively. 2 bisystronic trial, only 16 patients bridging BMT after CAR-T. The ratio is just 5% to now. The 1 year EFS was 100% and 80% for patients bridging BMT or not, respectively. It should be emphasized that we just recommend bridging transplantation after CAR-T for patients with MML and ZF384 rearrangements. We do not recommend bridging transplantation for other gene types, and we do not support all it. It is entirely up to their patient and their parents to make a decision. This figure shows the overall survival of bridging BMT or not after CAR-T in recent 2 trials. The reason is that even if patients relapse after CAR-T, they can also achieve CR again by salvage secondary CAR-T treatment. Some patients can be cured through bridging transplantation, while others still have a chance of a cure. Okay, let's note the question we talked about. Let's begin the CAR-T for TL lymphoma. The reason I just talked about the CAR-T treatment outcome of BL, I just want to illustrate that CAR-T treatment TL is very difficult. There are many problems that need to be solved. Generally, we need to overcome the following challenges. The first, the CAR-T cell will kill each other. That is CAR-T cell fratricide and the T cell aplasia. The second is tumor cell contamination during CAR-T preparation. And the third is there are some questions such as donor T cell implantation, GVHD infection, and high tumor burden. And the poor organ functional status or organ functional reserves. As CD7 is expressed on almost all TL and healthy T cell, CD7 CAR-T can kill TL cells. And at same time, it can also kill healthy T cell and other CD7 CAR-T cell. The result is CAR-T cell fratricide and T cell aplasia. The fratricide of CAR-T cell affects its expansion in vivo, thereby limiting the cytotoxic effect of CAR-T cell and leading to the inability to achieve CR. To prevent CAR-T cell kill each other, one of the best strategies to design CD7 CAR-T without surface expression of CD7. That is the intra-block technology. By constructing the CD7 binding domain in the lentiviral spectra, it can reserve intracellular CD7 expression. As CD7 could be fused with ER, rotation signal sequence, KDEL. So CD7 CAR-T cell can kill each other as the CD7 antigen is negative on cell membrane surface. Now, to our knowledge, there are many targets can be used in the T-cell TL CAR-T therapy, such as CD7, CD5, CD2, CD99, CCR9, CD33, 1A, 38, TRBC1, CD3, 48. CD7 is the most widely used target, but it is also highly expressed in healthy T cell and NK cells. Similar to CD7, CD5, CD2, and are also highly expressed in normal T cell and TL. CD99 and CCR9 are highly expressed in TL cells with lower expressed in normal T cell. CD33 also expressed in some TL patients, especially TP. CD1 is expressed in critical TL, which comprise 35 to 40% of all TL cases and has no expression on T cell or CD30 or hematopoietic progenitors. So CD1A CAR-T cell have been shown to be fratricide resistance, and it is a safe treatment for relapse refractory critical TL patients. CD38 is widely expressed in TL, BL, and AML. However, it also expressed on the surface of hematopoietic progenitors, which limited its application in CAR-T cell therapy. Similar to CD7, CD3 is also widely expressed in healthy T cell and TL, but CD3 not expressed in NK cell. Healthy T cell can be divided into two groups, CD4 and CD8 positive. However, CD4 and CD8 is low expressed on TL. There are some strategies for CAR-T cell fratricide and T cell aplasia. First, we can use the ER rotation signal sequence, KDEL peptide, and anti-CD7 SCFV to anchor in CD7 antigen in the ER and O Golgi, and block CD7 expression on the surface of CAR-T cell membrane. The second, we can also use the CD7, CD5, CD4, CD2 specific HGRA and CRISPR-Cas9 technology to knock out their DNA coding sequence in the genome level. Third, we can use TL specific targets which don't all have a weak expression on normal T cell, such as CD1A, CD99, CD33. One important issue in the field of CAR T cell therapy is the contamination of tumor cells, which subsequently generate CAR T modified tumor cells. For instance, when we have to knock out CD7 or other target molecules by ER retention or CRISPR-Cas9 method, the C7 and other targets of leukemia can be knocked out at the same time. So this kind of operation can prevent it from being recognized by other cancer cells, but can cause C7 negative relapse in the future. There have several methods to avoid T cell contamination, such as we can draw blood from patients of high risk group patients to prepare CAR T cell or reserve their freezed lymphocyte during the CR period. Thirdly, we should detect the MRD first if the PP MRD is negative. Second, we can use a lymphocyte from HRA matched donor, such as their sibling, their parent. The third, we can use CAR NK, CAR macrophage, CAR data T, CAR iNKT, or other universal CAR. And we also can use patient self lymphocyte with different CAR combination. At this point, we can knock out C7 through PDL or CRISPR-Cas9 and then put the C7 CAR and the C99 CAR virus together and co-transduced. This method can kill potentially contaminated C99 positive leukemia cells through CD99 CAR without causing C7 CAR parasite. The green cell is C7 CAR, co-transduced with CD99 CAR, and the orange cell is the TL cells. The C7 was knocked out by ER retention sequence, but CD99 is positive. So the C7 CAR, C7 CAR cell can kill the TL by CD99 CAR. That is to prevent the TL contamination. Now I will show some patients' information to introduce the strategy of CAR T cell on treatment of TL lymphoma. One of our patients, he was diagnosed TL when he was 10 years old. The bone marrow and mediastinum involved. Here is the basic information when he was diagnosed. There have 95% leukemia in his bone marrow. The immune phenotype, the CD7, CD5, CD99, and the cytoplasmic CD33 positive. Other CD7, 4, 1A negative. The patient was treated with CCG-AL 2015 protocol in medium risk group at Shanghai Children's Medical Center. This is the chemotherapy and the result. PBDL induction, MRD at day 19 and day 46. Tumor size was dramatically decreased after 3 months treatment. The first relapse happened 32 months after diagnosis. The relapse set were bone marrow and CNS. Then he received the second round of chemotherapy. Unfortunately, he relapsed again after 3 months chemotherapy, but the second relapse set was just happening in CNS. After 8 times intracycle injection, he achieved the CR again and also received the subsequent 12 months chemotherapy However, the third relapse also happened. The relapse that included bone marrow and CS. Luckily, in misfortune, HRE typing results show that this child and his mother are perfect matched. So we draw 48 microliter peripheral blood of his mother and isolated the T cell by C3 microbits. Then we transduce the C7 CAR antivirus and do the transduction efficiency determination and the cytotoxic test. The C7 CAR antivirus would use we used with ER retention sequence, KDER. So the C7 antigen was negative in the C7 CAR T cell. Where we can prevent the CAR T cell kill each other. And we use donor's T cell with the aim to prevent the tumor cell contamination. After 8 days culture, we have 1.5 million kilograms C7 CAR T cell. The patient was administered with vinorelbine and methylprednisolone to reduce the tumor burden, and received the lymphodepletion of fludarabine and cyclophosphamide during the CAR T cell preparation. The patient received 1.2 million kilogram of CAR T cell on day 0, where 250,000 cells intracycle injection. On the day before CAR T infusion, the result of bone marrow and CSF examination indicated that the leukemia burden in the patient's body is still very high. This is the phenotyping of the patient's leukemia cell before CAR T cell infusion. It showed that C7, cytoplasmic, CD3, CD5, CD38 were all strongly expressed. Even if CD33 and CD71 were all positive, but not all leukemia cells express their antigens. This is the basic vital sense of this child before and after CAR T cell infusion. The red triangle is the time point of CAR T cell infusion. On the day after CAR T cell infusion, the patient began to fever, and it lasts for a week, with temperature ranging from 38 to 39 degrees. Then the patient's body temperature rose between 39 to 40 degrees and continuously fever for 5 days in the second week after CAR T infusion. After that, his body temperature suddenly dropped to normal. The patient received 3 times of bone marrow smear and MRD detection. The day before CAR T infusion, MRD was 36%, and at day 8, the MRD was increased to 85%. Then cytokines such as interleukin 6 and interferon gamma dramatically increased, and the peak level happened during day 10 and day 11. And suddenly decreased after that. At day 14, the MRD was negative. We are also very surprised to this result. They are just 4 days MRD decreased to negative from very high level. The CAR T cell in his PB gradually increased to 1,500 per microliter at day 15. The flow dot plot shows the lymphocyte subpopulation in his peripheral blood. The purple subpopulation is the tumor cell, and the blue subpopulation is normal T cell, and the orange is the CAR T cell. From this flow cytometry result, we can see the purple tumor cell and healthy blue T cell disappear 1 week after CAR T infusion, where orange CAR T cell gradually increased on the 5th day after CAR T infusion, and then increased dramatically. On the day 11, the patient's PB is mostly CAR T cell, maybe about 80%. This is the dynamic changes of different cell subpopulation in the peripheral blood of other 3 patients. In a word, they all have the same dynamic fluctual dynamic status. There are the flow cytometry result of 2 other T-cell lymphoma patients. Unlike TAL, the population of tumor cells in their peripheral blood is very low. So we can't see a rapid increase in tumor cells in the PB. However, we can see that healthy T cells are gradually decreasing to disappearing, and the CAR T cells are rapidly increasing. At day 10 to day 14, only CAR T cells remained in the PB. We found that donor lymphocyte availability is very important in CAR T treatment. This child is an 8-year-old boy. He was relapsed 2 times after chemotherapy. At first, we used his father's lymphocytes to prepare CAR T cell, but 10 days after CAR T infusion, there was still a large number of tumor cells in patient's peripheral blood, and we did not see the expansion of CAR T cell. Instead, the number of CAR T cell was increasing. Therefore, we immediately draw peripheral blood from his mother to prepare CAR T cell. Under 30 days of CAR T infusion, the tumor cell in the patient's peripheral blood disappeared, and a large number of CAR T cells expanded. By the way, this patient and his parents are all have 5 of 10 HLA typing result. This is another patient. Due to the high expression of CD99 in leukemia cell, we collected the peripheral blood from patient himself and prepared CAR T cell targeting CD99. In the above figure, we can see that purple CD99 positive tumor cells are gradually decreasing, within 27% on the first day and decreased to 1.9% on the 9th day. However, the CD2 positive cell in peripheral blood, including normal cell and CAR T cell, are gradually increasing, with the population approaching 98% on the 7th day. But then it begins to decline rapidly. We wait until the 14th day, and the tumor cell in the patient's peripheral blood had not yet disappeared. This result indicates that the CAR T cell from the patient's own source are not highly active and cannot clean up tumor cells in the body. Then the patient's sister was chosen as the donor for CD7 CAR T cell. On the 10 days, day 10, after CAR T infusion, the population of tumor cell in the PB was 90%. However, on the day 13, the tumor cell in PB completely disappeared, and the CAR T cell expanded in large quantities. The story of this patient also proved that donor lymphocyte availability is crucial in CAR T treatment. There are many other challenges in treatment of TAL by CAR T, such as implantation of donor CAR T cell, severe GVHD, infections of T cell clearance, and a large number of misses. The implantation of donor CAR T cell can lead to bone marrow failure in patients who require immediately breeding hematopoietic stem cell transplantation after CAR T. The CAR T treatment time for lymphoma with solid masses is much longer than TL. It is difficult to manage GVHD caused by donor implantation of CAR T. On the one hand, the tumor cells have not been completely cleaned up, and we can't cure their CAR T cell. On the other hand, the patient's GVHD is very urgent. It needs clinical invitation. So we will be in dilemma. Considering this, it is very, very important to minimize the tumor burden before CAR T infusion. In addition to chemotherapy, other methods such as surgical resection and local tumor lesion therapy need to be considered. And in many cases, several measures need to be combined to reduce tumor burden. 2 years ago, we have a patient. She was 16 years old. She relapsed after chemotherapy and had a huge EDS panel tumor that was difficult to remove surgically and was not sensitive to chemotherapy. As we don't have experience at that time and don't know how to reduce tumor burden, although CAR T cell continue to function, the tumor didn't completely disappear in the end. Unfortunately, 2 months after CAR T cell infusion, she was infected with BKV and could not be reached for transplantation. Ultimately, she was diagnosed with severe bleeding and infection. We just talking about some CAR T treatment strategy and method for, but it is still a difficult point in clinical practice. I think it is possible to find specific antigen targets that are not expressed on healthy T cell, just on TL and T lymphoma. Thus, CAR T therapy can achieve the same therapeutic effect as the D lineage. The current strategy and method are not the final solution, and we still need to explore new and better methods. Thanks for listening.
Okay, thank you, Dr. Lee, for sharing your early results of using CAR T therapy to treat relapsed refractory TAL and the lymphoma. Okay, and may I ask 2 questions? Number 1, as compared to the B cell CAR T therapy, it seems that the CAR T for T cells takes a longer time to proliferate after infusion, after 7 to 10 days, whereas the CD19 CAR, they proliferate early. Why is it a difference? And secondly is about the hematopoietic stem cell transplant after the CAR T therapy for T cell. Is it always indicated?
Sorry, I don't. The second question.
For the second question is it transplant always required for CAR T in T cell ALL? Okay.
The first question is, I think CD19 antibody is special. It's very special, and the other cause maybe even if we use the CD7 CAR T, there are the ER mutation signal peptide aren't sorry. They also have the CAR T cell first set during the CAR T preparation, the T cell in the CAR T preparation. Yeah. The second question is now CD7 CAR T after CD7 CAR T treatment, almost all the patients need transplantation for that.
Okay, thank you. So is there any other questions from the audience about this exciting development using CAR T for treatment of these really very difficult to treat disease, always fatal? Okay, there's no other questions from the audience, and I hope that in the coming 1 or 2 years, we can hear more advances from Dr. Lee about this new development, hoping that we can offer a new strategy for treatment of these relapsed refractory TALL. At the moment, we really don't have too many options for this patients, but now it seems that CAR-T may still be working, but probably cannot be work alone as in the BALL. We may need stem cell transplant for this patient as a consolidation. Okay, if there's no more questions, I think we probably should come near to the end. Maybe Puna, can you say something about before we end, or Saji? Yeah.
Thank you, Shikong, and thank you, Dr. Akira, for thinking about such a interesting topic for our APHOG, where we can really put up some new. Can you hear me?
Yes.
Shikong?
Yes.
We can really think of some innovations in terms of 2 things. Finding out genomic profile of our all TLL and lymphoblastic lymphoma, because it has been shown that it has a ethnic background, like cultural. Professor Teachey showed very well that how it is different in different population in even North America, and we have such a heterogeneous population, so we can really find out as to what kind of different genomic profile we have. And secondly, Dr. Alice's talk was very inspiring for us to start using the already known drug for different indication, that is pentostatin, where nelarabine is not available because of the cost constraint. So we should very sincerely think about putting up a trial and use it in a best possible way. This is the remark I will make, and it should stimulate us to do something collaborative before we really can think of CAR-T therapy, which is still in a very evolving phase for T-cell leukemia lymphoma.
Okay, thank you, Puna. Saji, do you have any things to add on?
Yeah, thank you so much, Dr. Kung Lee. It's I really congratulate all 3 speakers. It was really nice, exciting talks, and as Dr. Purna said, that can provide us some baseline aspects for moving for the clinical trials in LMICs within APHOG group. So I really congratulate all 3 speakers. All wonderful talks. Very well done. Thank you so much.
Thank you. So Akira, you will have the final words before we close this symposium.
Yeah, I have nothing special, but thank you very much for very nice presentations by 3 speakers, and also 3 moderators did a good job today. So now we are closing this symposium, but we have one more virtual meeting of APHOG this year. That is APHOG Global Seminar will be held on December 6th, Wednesday, at the same time. The theme of that APHOG Global Seminar this year will be brain tumor. So please look forward to listen to that seminar again. Then see you again at that time. So
okay, see you. Thank you.
Yeah, thank you.
Thank you.
See you again.
Thank you all.
Bye-bye.
Exactly at 9, we finish on time.
Thank you. Thank you. Thank you to
so
all
much.
speakers. And
Thank you. Thank you, Anita, for your support. Yeah.
Thank you all.
Thank you, David.
Thank you. Thank you, all the speakers. Yeah.
Thank you, Benshang. Mm.
Bye.
Bye.